bleeding in the first trimester, and approximately 50% of those will end in pregnancy loss. According to Health Quality Ontario, there were almost 50,000 ED visits for early pregnancy complications, including bleeding and loss, in our province between 2017 and 2018. Larger centres like TOH will see on average 5 to 10 women per day who are experiencing pregnancy loss. And before we begin, please know that throughout this presentation, I will be referring to pregnant women as the primary patient population for purposes of simplification. But of course, this applies to any patient with a uterus that's capable of carrying a pregnancy. Here are the objectives for today's talk. And here is a general differential diagnosis for bleeding in the first 20 weeks of pregnancy. The left side of the screen outlines our most common causes specific to the pregnancy that we commonly think about. But on the right side of the screen, this is outlining a few additional causes that we may want to consider in our workup. Because remember, just because a woman is pregnant doesn't mean that she can't also have a concomitant STI or a cervical lesion, for example. This is our current ED-TOH algorithm on the workup and management of bleeding in early pregnancy. We're going to make our way through this algorithm as we work through a few common clinical cases today, and I'll be highlighting some of the key decision points along the way. A quick note on unstable patients who are excluded from this algorithm there at the top. These patients require urgent OB-GYN colleague consultation in the emergency department, and they're not going to be the focus of our talk today. But before we jump in, there's one point of clarification that will be relevant to each and every case we discuss today, and really each presentation of early pregnancy complication that we see in the ED. And that's the question of whether or not this patient should or even can get a radiology performed ultrasound in the department today, usually, of course, in the form of a transvaginal scan. Now, this isn't strictly outlined in any literature, but in general, the culture in our ED, and I think a reasonable approach, is to consider two key patient presentations. One is the unstable patient, and one is the patient with a concern for a symptomatic ectopic pregnancy, particularly if that patient has not had any previous radiology performed imaging in this pregnancy. And then in this gray area is the patient with no access to reliable follow-up. But I'm hoping that this will be kind of an uncommon occurrence after I share with you a few great options for follow-up resources today. So case one is Tracy. She's a healthy 30-year-old female, a G1P0 at 7 and 5 weeks gestation, presenting with cramping and bleeding. She is known for an IUP previously identified on a dating ultrasound. Her labs are drawn at triage, her beta is 52,000, and she is Rh positive. She has only light bleeding, she appears well, she's vitally stable, and her abdominal exam is benign. But you recall a few additional key points to elicit on history, including the following. You ask about her last menstrual period, her vaginal bleeding in terms of amount and characteristics, any other vaginal symptoms including discharge or symptoms of infection, her pain, including the severity of the pain and the location, any symptoms of hemodynamic compromise such as dizziness, orthostasis, or syncope, and a past medical history with an emphasis on her obstetric history. So now, with the ED on wheels and busy nurses running all around you, you ask yourself, do I need to do a pelvic exam today? I only want to touch on this very briefly because our very own Dr. Kate O'Connell provided an excellent summary of the controversy around pelvic exams in patients presenting with vaginal bleeding in early pregnancy in her grand rounds from 2022. But to summarize her key points, the ED and OB-GYN literature conflict on this topic, and overall, the evidence is poor and lacking for either argument. She provided us a low-risk checklist for patients that may safely forego the pelvic exam, including patients with a first trimester IUP, only light bleeding and stable vital signs, minimal pain, no suspicion for an alternate etiology such as trauma. They've already completed a urine STI screen, and they have access to reliable, timely follow-up. For all other patients, the pelvic remains mandatory. And just as an aside here, because I'm going to mention like the degrees of bleeding a lot in this talk, a good rule of thumb is that bleeding that's lighter than the patient's usual menses is minor and reassuring. Bleeding that's heavier than menses should make you pause and consider maybe imaging that patient today and definitely doing a pelvic. And true heavy bleeding is when the patient soaks through a maxi pad in 1 hour for 2 or more consecutive hours. So Dr. O'Connell continues that given the lack of evidence to guide our practice and refute the current OB-GYN literature that says we really do need to do a pelvic in all of these patients presenting to the ED, she emphasized that we are never wrong to offer the pelvic. She said shared decision-making is likely the best way forward for the patients that don't fall into the category of the mandatory exam. So let's go back to Tracy's case. On further history, her answers are all reassuring. She does not meet the high-risk criteria for a mandatory pelvic today, and so through shared decision-making, you decide to forego it. You confirm a positive IUP with a fetal heart rate on your bedside POCUS. You agree there's no role for an additional radiology performed ultrasound today because she has an IUP and she's stable and minimally symptomatic. And so ultimately, this patient is diagnosed by you with a threatened miscarriage. And this means that there's clinical evidence of bleeding or cramping, but there's ultrasound evidence of fetal viability. You discharge her from the ED with a plan to follow up in the early pregnancy evaluation clinic. So speaking of the EPEC, this is a good time to talk about the role and benefits of this service. This is not something that is unique to Ottawa and has actually been implemented and considered the gold standard of care in the United Kingdom since at least the 1990s. Early pregnancy evaluation clinics provide a centralized, multidisciplinary service for patients who are experiencing early pregnancy complications. They can arrange for serial assessments, betas, checks, and pelvic ultrasounds when needed. And with an initial goal of diverting these patients away from the ED and reducing unnecessary hospital admissions, EPECs have subsequently been found to provide even more cost-effective care, more timely management, and improved patient satisfaction. However, a 2019 survey of Canadian EDs published in CGEM found that despite all of these potential benefits, only 54% of Canadian EDs currently have access to an EPEC. Luckily, we are one of the 50%. And Tracy, our patient with the threatened miscarriage, can certainly follow up there. So shout out to our very own Dr. Lipinski, who has worked very hard to find the best way forward, given that historically patients were seen within 1 to 2 business days, but recently their wait times have significantly increased due to increased demand. He has created the clinic's new triage process, which is outlined here. And in Tracy's particular case, patients with a threatened miscarriage will be triaged to the lowest priority, and this makes sense. But maybe you're asking yourself, is there anything that we should offer her in the meantime? How do I counsel her on the next steps? First, it's important to explain to patients that there are no effective interventions to prevent pregnancy loss in the first trimester, and accessing a specialist or having a repeat ultrasound today will not change the course of this pregnancy. But other than that, there really is no clear consensus in the literature on the expectant management of these patients. Specifically, we know they need serial betas and pelvics, but when? Pelvic ultrasounds, that is. So a reasonable approach across the data that I read was a follow-up within 1 to 2 weeks. So in the straightforward threatened miscarriage of a known IUP in a minimally symptomatic patient, following up at our EPEC clinic within 2 weeks is totally fine. However, it would also be appropriate to refer her back to her family doctor or her own obstetrician, if they have one. And this approach is supported by our ED algorithm. Tracy is well appearing and has an IUP that appears viable on POCUS. So if she has good alternative follow-up, referral to the EPEC is likely unnecessary. And in fact, when I spoke with Dr. Glenn Posner, who works at our local EPEC, he asked me to reiterate this point. Always ask the patient if she is already being followed by another provider in this pregnancy to avoid double dipping in the EPEC. But regardless of the follow-up plan, good patient education will be key here. If the bleeding stops, tell this patient to continue her routine antenatal care, with the assumption being that this is now a viable pregnancy. In terms of her lifestyle management, we do not recommend bed rest. It has not been shown to be helpful. And pelvic rest, in other words, avoiding tampon insertion, intercourse, and excessive exercise, is often recommended, but it's also not grounded in any evidence. But definitely tell her to return to the emergency department if her bleeding becomes heavy, if her bleeding persists beyond 2 weeks, because that could be suggestive of a miscarriage with retained products, or if she develops a fever, which may suggest infected retained products of conception. So let's move on to case 2, Renata. This is the exact same clinical vignette as case 1. A woman at 7 and 5 presenting with cramping and bleeding, except this patient is Rh negative. Per our ED algorithm, and I think most of our education on this topic up until this point, at least mine, any Rh negative patient presenting with bleeding in pregnancy should receive Rh immunoglobulin, right? But as you've probably heard by now, there's been some big changes in the recent Canadian guidelines on this topic, and we're going to take a dive into it. So we'll start with a brief physiology review. The rhesus or Rh system includes 50 possible antigens that can be found on the surface of our red blood cells. But the D antigen is the most common and the only antigen that we have available prophylaxis for. Therefore, when we simplify by saying that a patient is Rh negative, what we actually mean is they're Rhd antigen negative. Alloimmunization is the process of an Rh negative mother producing antibodies to an Rh positive fetus, and this can occur with mixing of the fetal and maternal circulation. This can result in hemolytic disease of the fetus and or newborn, most commonly in subsequent pregnancies, but it is possible to also happen in the current pregnancy. Rhd immunoglobulin, or Rhig for short, is a blood product containing a high titer of antibody to Rhd antigens of red blood cells. It is obtained from pooled human plasma and is effective in the prevention of Rh alloimmunization if it's given within 72 hours of a sensitizing event. The use of Rhig has been a major public health success story over the last 50 years. In Canada, prior to the implementation of immunoprophylaxis, the incidence of Rh sensitization in Rh negative moms who delivered Rh positive babies was 7.2%. When we started introducing a dose of Rhig in the early postpartum period, the incidence dropped to 1.8%. And now that we add a routine antenatal dose at 28 weeks gestation, the incidence has dropped further to 0.07%. But it turns out that internationally, when it comes to prevention of Rh alloimmunization in early pregnancy, the leading organizations in obstetrical care have been divided on this topic for some time. Specifically, there has been much debate about whether or not there is a large enough volume of fetal-maternal hemorrhage to result in sensitization during bleeding events in the first trimester. In 2019, Wiebe et al. Compared rates of alloimmunization in Canada, where RHIG prophylaxis was universal, to the Netherlands, where prophylaxis was not required before medically and surgically induced abortion in the first trimester. Using mathematical modeling, they found that clinically meaningful perinatal anti-RHD antibody levels were similar between mothers in the two countries, despite a higher baseline rate of Rh negative status in the Netherlands, plus a lower rate of RHIG prophylaxis there. And this suggested it may be safe to forego RHIG treatment at early gestation. In 2023, Horvath et al. Published a multi-center observational prospective cohort study using flow cytometry that detected circulating fetal red blood cells in maternal blood samples before and after induced medical and surgical abortion in patients under 12 weeks. They confirmed induced first trimester abortion is not a risk factor for Rh sensitization, indicating that Rh testing and treatment are unnecessary before 12 weeks gestation. The Society of Family Planning in the USA now has a consensus statement recommending providing Rh immunoglobulin only after 12 weeks gestation in any type of abortion care. And just this year, after conducting a systematic review and grade analysis on the topic, the Society of Obstetricians and Gynecologists of Canada updated their clinical practice guideline to reflect the evolution of this evidence, stating, regardless of the type of exposure, RHIG is not recommended under 8 weeks. And in fact, the SOGC recommends not even checking their Rh status under 8 weeks. But then they go further to say that RHIG is not necessary under 12 weeks, but it can be considered in the 8 to 12 week range for mothers who are more risk averse. And of course, they continue to recommend RHIG to 12 weeks and above in all cases. So why all the debate? Why don't we just give this to all Rh negative moms? Is there any harm? And honestly, not much on the surface, it seems. Specifically at the doses used for prophylaxis in pregnancy, there seems to be very little risk. Like most blood products, there is a risk of anaphylaxis and infection, but there have been no reported cases of viral transmission by the current Winro product that's used in Canada. An interesting and true risk that I think we should all be aware of is the potential for falsely elevated blood glucose readings on home monitors for some patients. There have been case reports of fatal home over-administration of insulin as a result of this. But from an ED perspective, it is important to consider any potentially unnecessary intervention that may result in longer ED stays and increased cost, and so that might be an important argument here. And most recently, there has been a noted shortage of RHIG across North America, with calls to conserve our supply where possible. Yet, on the opposite side of this argument, some groups say there is greater benefit than risk overall, and universal use is still recommended in first trimester by some societies, like the American College of OB. So with all of that said, you are safe to not offer it under 12 weeks within the context of our leading Canadian guidelines. However, particularly in the late first trimester, shared decision-making is probably the best way to go, considering that the controversy remains. Now, I've only ordered Winro in our ED a couple of times, but it was always a little bit of a headache. There seems to be some confusion each time. I wanted to clarify a couple of points. So Winro is the only RHIG product that we have access to at TOH, and specifically, we do not have ROGAM. But the mechanism of action and the dose is the same between the two products. But one thing that is not the same, however, is that Winro can actually be given intravenous as well as intramuscular. And our nurses might need reminding of that, but often these patients already have an IV and we can save them an extra poke. The dose to remember is 300 micrograms. Technically, under 12 weeks gestation, should you choose to offer Winrow through shared decision-making, a lower dose of 120 micrograms can be used according to the SOGC, but that dose is just not available at TOH, and so it's 300 micrograms for everyone. Now, the dose of RHIG after 20 weeks gestation is nuanced, but luckily, our transfusion medicine lab will make it very easy for us. And Dr. Buyuk Dare shed light on this very interesting process for me. A single standard dose of RhoGAM or Winrow, 300 micrograms, will always be sufficient under 20 weeks gestation. However, beyond that, we need to measure the amount of fetal-maternal hemorrhage at that time to determine the required dose. So Dr. Buyuk Dare recommends starting with this, the Rosette test, which I'd never heard of before. And he says if you order this test, then the transfusion medicine lab will just take it from there. The Rosette test is a sensitive, qualitative screening test for fetal-maternal hemorrhage. This test will be negative if the amount of fetal-maternal hemorrhage is small, indicating that a single standard dose of 300 mics will be safe, even over 20 weeks. However, a positive Rosette test will then prompt our lab to proceed with the quantitative Kleihauer-Bechdie test, which will determine the total volume of hemorrhage, and the lab will then tell us exactly how much Winrow to administer. So, back to Renata's case. This patient is also diagnosed with a threatened miscarriage at 7 and 5 weeks, gestation. Her management plan is the same as our first case and will include education around pelvic rest, what to watch for at home, and when to return to the emerge. You recall the most recent SOGC guideline and do not offer her a dose of Winrow, and she leaves the ED promptly with planned follow-up in 1 to 2 weeks, as we previously discussed. Okay, now in our third case, things get a little bit more complicated. This patient, Missy, is further along in her pregnancy at 12 and 2 weeks gestation. Luckily, she has also already had a previous staging ultrasound showing an IUP with a fetal heart rate. She presents today with abdominal pain and cramping. She's also Rh negative, and at over 12 weeks, when you walk into the room, you know you're going to have to get blood consent and order her Winrow. Her exam is clinically reassuring, but on bedside ultrasound today, you identify an IUP without a visible fetal heart rate. The patient looks at you and asks, "What's wrong?" So you suspect Missy is experiencing an early pregnancy loss. This is often the preferred terminology, but it remains synonymous with miscarriage and spontaneous abortion. The ED diagnosis of EPL can be challenging, especially because we're usually seeing these cases in a single assessment in time, when really serial betas and ultrasound testing is often needed for confirmation. However, we actually have very clear diagnostic transvaginal ultrasound criteria for early pregnancy loss from the Society of Radiologists in Ultrasound. These criteria can be used in the first trimester, so under 13 weeks, and are more stringent than previous criteria and have been found to have a specificity and positive predictive value of 100%. So that means it would be extremely unlikely to diagnose an EPL when there's actually a viable pregnancy. And these criteria are universally accepted across the SOGC, ACOG, and Health Quality Ontario. However, these criteria have not been validated through use of transabdominal ultrasound, and therefore the majority of ED physicians will not be able to make this determination at the bedside with ultrasound. But what if a patient comes to the ED with a community ultrasound reporting these findings? Or you happen to proceed with a radiology performed ultrasound in the ED and this is the result? So I'm providing this for you today for two reasons. First, the literature shows that patients with early pregnancy loss often experience a delay to diagnosis and treatment. And so at the very least, sharing your high suspicion for an EPL today will prepare your patient for the likely next steps, which may include passage of products of conception at home and confirmation of pregnancy loss on her follow-up appointment. And also, we can actually offer these patients treatment in the eMERGE. So what does the management of EPL look like? We have 3 options available for all patients presenting: expectant management, medication, or surgical abortion. The major obstetrical societies are all in agreement here. Except for the cases meeting clear indication for surgical management, which are listed on the bottom left, there are no differences in major outcomes between these 3 options, and so the choice comes down to patient preference. However, the time to completion of the pregnancy evacuation does differ, and conservative treatments run a higher risk of treatment failure, resulting in retained products. Expectant management is what most of us are already doing. It should generally be limited to the first trimester. And with adequate time, expectant management is successful in achieving complete expulsion in 80% of cases, but it can take up to 8 weeks. The timing of tissue passage is unpredictable. Expectant management is most likely to be successful in patients actively symptomatic from their miscarriage today, while less symptomatic patients are more likely to experience retained products with expectant management. So, compared to expectant management, medical management of early pregnancy loss offers patients more control over the timing of tissue passage. It decreases the time to expulsion and increases the rate of complete miscarriage, reducing subsequent need for surgical intervention. Mifegymiso is a combination of mifepristone followed by 1 to 2 doses of misoprostol. It is more effective than using misoprostol alone, and it's currently the recommended treatment of first trimester medical abortion in Canada. The MIFI regimen for medical treatment in EPL is the same as that for an elective abortion. And of course, the approach to abortion care in the ED was outlined by our own Dr. Pascal King in her grand rounds last year. I encourage you to take a look at her blog post for more. And don't forget, just like all of our first trimester POCUS scans in the ED, this too is a billable service. And the third and final choice for management of EPL is surgical intervention, usually in the form of a suction aspiration. I won't talk much about this, of course, but it is helpful to know that surgical management of incomplete pregnancy loss can be chosen as the initial management option, if that's the patient's choice. But it's also the next step should there be failure of evacuation by the initial approaches. As ED docs, we can refer on for surgical abortion care, but if the patient elects for initial expectant or medical management today, patient education and preparation is going to be key. Counseling should emphasize what to expect. They may have bleeding that is heavier than menses and potentially accompanied by severe cramping. There will be passage of clots and products of conception, and they should be encouraged to use analgesia, particularly NSAIDs. And counseling should also emphasize what to look for and when to return to the eMERGE. Excess bleeding is one of the big ones, but also, on the other hand, if they do not experience any bleeding or passage of tissue, that's also a sign to return. They should also monitor for symptoms of infection, but a transient fever lasting under 24 hours is common after misoprostol, and the patient should be encouraged to take Tylenol or Advil and return if the fever lasts beyond 24 hours or is associated with vaginal symptoms of infection. The SOGC guideline on abortion states that all patients require follow-up within 1 to 2 weeks. But the method of determining if the pregnancy evacuation is complete can vary by provider. Here are the key points to know. A repeat ultrasound is not usually required. If there is a clear history of expulsion at home and the bleeding is resolved or resolving, then no further confirmation is required at all. But an 80% reduction in the beta HCG after 7 days can also be used for confirmation. If none of these criteria are met, the patient will require further workup for retained products of conception. As for follow-up, as we've already mentioned, we're lucky to have our EPEC here for these patients. And these patients will be seen and triaged within 1 week. However, whether you're working in a rural area or in the city, offering medical management of EPL from the ED can jumpstart this process. And they may even be able to confirm completion of the miscarriage by the time she's assessed in the EPEC, limiting delays in her care. So let's return to Missy's case. Recall she's pregnant at 12 and 2, presenting with cramping and bleeding, known for a previous live IUP, but on ED POCUS today, you cannot see any fetal cardiac activity. She then provides additional history that she was actually sent for an ultrasound this morning by her family doctor, and she's wondering if that result is available. So you confirm on clinical viewer. There's an IUP with a crown rump length of 8 millimeters, but no fetal cardiac activity in keeping with pregnancy failure. So you come up with this plan. You diagnose the EPL, or disclose it to her, I should say. You discuss her options, and she opts for medical management with mifenymiso. You counsel her on what to expect and when to return to the emergency department and provide her with multimodal analgesia, and you give her a dose of Winro because she's over 12 weeks. And finally, you refer her on to the EPEC for follow-up. Okay, let's move on to case 4, Pula. This stem is similar to the others, except this patient has had no previous imaging, and she's estimated to be 6 + 1 weeks in gestation by LMP. Her beta HCG is quite low. In fact, it's below the discriminatory zone for transvaginal ultrasound at 1200 today. She appears well, she has a reassuring exam, but not surprisingly, she is non-diagnostic for intrauterine pregnancy on your bedside POCUS. You're thorough, so you add a fast exam, which is negative for free fluid. And so now this is a case of pregnancy of unknown location. A pregnancy of unknown location is a temporary state of pregnancy where the beta is positive, but the location of the pregnancy is unknown. And that is until a final diagnosis can be made by means of serial assessments, betas, and ultrasound. The possible 3 ultimate outcomes of a PUL include an IUP that may be viable and developing, or it may be non-viable, a miscarriage, or an ectopic pregnancy. And of course, our greatest concern here should always be for an ectopic. The SOGC reminds us that until a location is confirmed, a pregnancy of unknown location should always be considered potentially ectopic. And here's why. Although ectopic pregnancy occurs in about 2% of all pregnancies, it comprises over 10% of ED patients presenting with first trimester bleeding, and up to 14% of pregnancies of unknown location. And so the SOGC also appropriately refers to PULs as a transient state used to classify a patient at risk for ectopic pregnancy. Now, looking back at our current ED algorithm, a key decision point is determining if the pregnancy is intrauterine or not. But you're a skilled POCUS practitioner, and you've already determined that this patient is an ND IUP, also known as a pregnancy of unknown location. So the next question is there a high suspicion of ectopic or not? Now, this is where we really have to look at the patient in front of us. There is no one historical or exam feature that can say definitively that the patient in front of you has an ectopic pregnancy, especially in the stable, well-appearing woman. Instead, it comes down to always maintaining an index of suspicion in any patient that has not been diagnosed with an IUP, using your already excellent grasp of these risk factors and clinical features of ectopic listed here. Here are a few additional key points to remember when you have a patient with a PUL. You cannot diagnose a miscarriage in a patient with ND-IUP if they did not have a previous confirmation of an IUP. Yes, they could have a near complete abortion if the uterus appears to be empty, but they could also have an ectopic. In the same vein, do not treat a stable patient with a PUL empirically as a miscarriage or an ectopic using misoprostol or methotrexate, as this could harm a viable developing IUP that's just not visible yet. Clinically well, low-risk PULs, meaning patients that are minimally symptomatic and without clear risk factors for an ectopic, can be safely managed as an outpatient with reliable early follow-up, but more on that in a bit. Do not use a single beta-HCG level to determine the role for an ultrasound today. Specifically, do not let a beta-HCG below the discriminatory zone influence your decision to obtain a radiology-performed ultrasound today. We know that betas in ectopics are highly variable, and they are often below 1500. Instead, determine the need for ultrasound today based on the patient's clinical presentation and risk factors. Do not use a single beta to risk stratify your patient's likelihood of ectopic for the same reason. If discharged home, all patients with a pregnancy of unknown location require a repeat beta-HCG within or at 48 hours. And with that repeat level, the ratio between the two beta measurements taken 48 hours apart can actually be used or may be able to be used to stratify the risk for the ectopic. This 5 Things to Know About Pregnancy of Unknown Location publication in CGEM from 2020 is an excellent short read on this topic. They emphasize that all patients need a repeat beta in 48 hours, which is endorsed by most major obstetrical societies. They incorporate the concept of the beta-HCG ratio into their management algorithm for PUL. From an ED perspective, this may be more relevant in a rural or remote setting without access to an EPEC. So let's go back to Pula's case. On your assessment, you rule out any historical risk factors or clinical features of an ectopic pregnancy. And you determine that she does not meet the criteria for a radiology-performed ultrasound in the ED today. And you come up with a safe plan for her, which includes follow-up in 48 hours and excellent return instructions. Now, from a follow-up perspective, pregnancy of unknown location provides a particular challenge to our OB care providers. The general idea is that these patients need very close follow-up, serial assessments, betas, and ultrasounds until the diagnosis becomes clear. If the location of the pregnancy is never identified, but the beta-HCG is decreasing, it's often just followed until it reaches 0. But if the beta is persistently elevated or rising, then this is concerning for an ongoing ectopic. And so these cases of PUL are where our EPEC referrals must truly be prioritized. Okay. To close things out, we are going to take a moment to talk about how to deliver patient-centered care in these settings within a busy eMERGE department. A mixed method study from 2019 found 3 key sources of patient dissatisfaction in the ED during these often distressing visits, which is quite consistent across the literature. The areas patients want us to improve include expedited evaluation of early pregnancy problems, clear communication, and better emotional sensitivity. Addressing point number 1 is not so easy in our current system, but sometimes just knowing what resources are available to you can make a world of difference when providing a patient the follow-up that she needs. So here's a few helpful things that I have learned in preparation for this topic. These lists are definitely not exhaustive, however. First of all, it may also be helpful to know that when we refer our patients to the EPEC, they will connect any unattached patients with an obstetrician for the remainder of that pregnancy. However, additional community OB resources in our city include, but are not limited to, the Origins Clinic. The Byward Family Health Team and Apple Tree Clinics also have access to dedicated OB-GYN specialists, and I suspect other primary care clinics do as well. Their referral information is listed on their website. There's 2 awesome websites called mamadoctors.ca and Ottawa Docs Deliver, and these list available FMOB providers that are currently taking patients, and I heard that their wait lists are just about 2 weeks. So those are great resources for patients that just need ongoing routine prenatal care. This case came up for me last week, and I didn't really know what to do about it. So OB care for non-OHIP patients, and I don't mean RAMQ, I mean like immigrants and refugees that don't have OHIP, can access free care by midwives in this city, and you can Google them, there's tons of options. And that's due to a separate pool of government funding for them. One particular midwife, Sarah Beckman, who works with the Community Midwives of Ottawa, works as a liaison for non-OHIP patients that need to be connected to an obstetrician for more complex care, and that referral maintains the separate pool of funding for non-OHIP patients. And I also heard that the FMOB docs at the Somerset West Community Clinic might also take non-OHIP patients. And then the lovely Dr. Jim Yang has also created a few additional helpful resources in the form of dot phrases. One is our DC Abortion Services dot phrase, which provides a list of local abortion care services available. And they're mostly by patient self-referral. And they can provide elective terminations as well as medical or surgical evacuation of incomplete miscarriages that we see in the emergency department. And then there's the DC EPEC smart phrase that provides a handout for patients going to the early pregnancy eval clinic, and the DC EPL handout, which is awesome and provides a lot of information for patients and their families suffering from an early pregnancy loss. So in addition to knowing what resources are at your disposal, I think that by improving on points 2 and 3, we might be able to at least find some shared understanding around the frustrations and the timeline for care that our patients sometimes face. And by that, I mean, take a moment to communicate clearly why, for example, a stable patient with a threatened miscarriage does not require a radiology-performed ultrasound in the ED today, in addition to the bedside POCUS that you did, and explain how this will not impact the course of the pregnancy. Acknowledge your patient's frustrations that come with an uncertain prognosis in her pregnancy, and let her know what to expect at home, that she could continue to have bleeding and cramping, and that is likely a sign of a miscarriage. Tell these patients that there is nothing that they did wrong to cause early pregnancy bleeding or loss, and that many women who bleed during the first trimester will go on to have a healthy pregnancy. And if not, one miscarriage is not associated with increased risk for infertility in the future. And take a second to ponder this discordance in priorities between physician and patient, and how this could lead to a perceived lack of empathy. I think it's important to address this elephant in the room in these cases, to remind ourselves that there is a whole patient in front of us, and that we should take a second to explain the medical process and why we're doing what we're doing. A shout out to our EPL working group that revamped our early pregnancy loss resources in the last couple of years and compiled them into an EPL binder found in our urgent cares. And this is largely a nursing resource, but it reflects all the current best practices from research in Canada on EPL patients managed in the ED. And this 40-page document from the PALE network is a key resource for families experiencing EPL. It talks about everything from the process of pregnancy loss to how to manage their physical and psychological health, and it's pretty awesome. And it's available for free in our EDs as well as online. Thank you.